Welcome, everybody. Thank you for joining us. As you can see, we are recording today's session. My name is Patty Taylor. I am the Director of Quality and Patient Safety at the Dallas-Fort Worth Hospital Council. We are so excited to have you here today and our guest speakers. I want to start out by thanking our Sepsis Strike Force Committee. They are committed this year to provide education monthly, and we have done a great job of doing that, and all of you have shown us that it is needed. And thanks to JPS for providing the CNE, because it's always nice to sit through a great education but also get a CNE out of it, so we really do appreciate that. We have our chair, Sue Bruce, of the Sepsis Strike Force, and then Jessica Aguilar, who's one of our presenters, is our co-chair and will be our chair next year, so we're super excited to have them. So at this time, I am going to give you a few housekeeping items. I see you're writing in the chat. That's awesome. Keep it up. We want to know why you're here, even what future topics you would like to hear. And then after the presentation, we are going to go into our meeting. Everybody is welcome for the half-hour meeting if you want to hear what the Sepsis Strike Force is up to and what we're doing. I do have everybody in listen-only mode. When we go to meeting, we will change that back where you can interact with each other. If you have any questions during the presentation, just type them in the chat and I will help read them to both Jesses so they can try to answer them for you. I will be sending out the link for the evaluation to everybody who stayed in this meeting at least 50 minutes. We do record how long you've stayed, so that is a requirement to collect the CNE. You have 10 days from today, I'll put the date in the email, to do the evaluation and claim your CE, and then JPS will email the certificate to you. So at this time, I would like to introduce one of the team members that'll be speaking to us, Jessica Aguilar. She's been a nurse for 7 years and currently serves as the backbone of the JPS sepsis team. Her background experience includes pediatrics, education, and emergency medicine. Prior to becoming an RN in 2015, she was licensed as a paramedic in 2011 and an EMT in 2004, so she has lots of experience. She's a wife and a mom to a 7-year-old. In her limited spare time, she and her husband are building a photography business, and I'm so happy to congratulate her. She will graduate with her master's in nursing administration from Texas Tech in the fall, so congratulations, Jess. At this time, I'll turn it over to both Jesses and we'll start the presentation. Thank you.
Thank you, Patty. I appreciate that introduction. So like we said, Patty went over the CNE disclosure statement. This is just on here for anybody maybe that had jumped on late. But today we're going to be talking about maternal sepsis, and we're going to talk about what matters most when it comes time to recognize it. So I have the beautiful Jess Brozio over here with me. She is my sidekick for this. She is the AP Perinatal Levels of Care Coordinator here at JPS, and they just had a wonderful, successful maternal levels of care survey. So I want to give her a shout out for that. All right, so we have nothing to disclose. We have no conflicts of interest, and we're not getting paid to do this presentation. So some of the objectives that we want you to learn from this presentation today are, we want you to be able to define what maternal sepsis is and the risk factors that encompass that. We also want you to be able to know the difference between what SIRS is, your systemic inflammatory response system, sepsis, and then severe sepsis criteria. And then how does maternal sepsis make that different? We also want you to know we have an algorithm here. It's a maternal sepsis algorithm, and we want you to know how to apply that algorithm. Your company, your hospital may have your own algorithm, but we just want you to be able to know how to apply what is different for maternal sepsis to your current practice. Then we want you to be able to utilize the OB sepsis checklist in your nursing practice, and this is an evidence-based practice tool that Jess and I designed so that this would be something that maybe you can take back to your organization as well. And then, of course, understand the care that is required for the maternal sepsis patient because it is different than your normal sepsis patient. So we're going to go over some maternal sepsis statistics. These, I just kind of want to go over a couple of them. One of them is that 47 to 50 million cases per year for maternal sepsis. That's a staggering number. And then at least 11 million deaths per year. So we want to make sure that we're taking maternal sepsis very seriously. Understand that 1 in 5 deaths associated with sepsis are worldwide. So, I mean, that's a really high number. Sepsis is also the #1 cause of hospital readmissions, healthcare costs, and the #1 cause of death in hospitals. And it's actually the #1 cause of death in ICUs as well. 40% of cases are children under 5. So my daughter was that statistic. She had pediatric sepsis and she was 18 months old. So it can occur to anyone. About 85% of sepsis actually occurs in the community. So something to just kind of think of with that too. And then just kind of to remember that an infection like pneumonia, it is a local infection, but when it's your body's response to that infection, that's what indicates that you have sepsis. So, and we'll go over some of those things in just a minute too. So how do we define maternal sepsis? This is a life-threatening condition defined as organ dysfunction resulting from infection during childbirth, pregnancy, post-abortion, or postpartum. So beginning 7 of 2022, and this is huge for maternal sepsis, CMS, so the Center for Medicare and Medicaid, are actually recognizing maternal sepsis, and they're defining it as 20 weeks of gestation through 3 days postpartum. So just wanted to let y'all know that some of the information in this presentation was prior to this being rolled out. So we just want to make y'all aware of it. But that's a huge win for maternal sepsis in that they're recognizing that. And, you know, just remember sepsis can be very insidious in pregnancy because they may look really, really well, just kind of like babies do, and then they just decompensate super fast and they go into shock. So just to be mindful of that. So what are some risk factors? We talked about a couple, but what are some risk factors? So one of the biggest things that we see here at JPS is no prenatal care. So they either may have like group A or group B strep. They may be 3rd trimester and haven't had any prenatal care. Of course, any preterm labor puts them at a higher risk of developing an infection. And premature rupture of membranes, especially at that 24-hour mark, is where you typically see that chorio kick in. So just to be aware of that. Chronic conditions, diabetes, hypertension, and this can be hypertension prior to getting pregnant, or it can be hypertension while you're pregnant. Obesity, of course, because it increases your body habitus, and then COPD, because obviously that affects your lungs. So your socioeconomic status, this can also affect your maternal health of you and your baby. So like we said, lack of prenatal care, but the chronic conditions, high-risk pregnancies, access to healthcare. Some people don't have access to healthcare. They don't have running water available. So their SES could come into play with that as well. Residing in a jail, group home, or being homeless. And again, this speaks to JPS a lot. A lot of our patients are homeless. We've had quite a few jail pregnancies that have developed chorio. So just understanding that all that puts them at a higher risk of developing maternal sepsis. And then intrapartum or post-delivery C-section, any kind of stress to mom or baby can also put you at a higher risk of developing maternal sepsis. And then, of course, English is a second language. Make sure if you have a patient that speaks Vietnamese, Burmese, Spanish, we're always using a documented interpreter because we want to make sure that we are getting the correct and accurate data from them and input from them. And then at the very bottom, it says sepsis is the most common cause of maternal death in Texas, and it is. And so we want to try to break the chain of that. All right, I'm going to turn it over to Jess.
All right, so this is one of my favorite slides. So the leading causes of maternal sepsis. I'm just going to briefly define these. So antepartum, excuse me, that is the period while the patient is pregnant. So that is from conception up until they go into labor, okay? Intrapartum is considered during labor, and then you have the immediate postpartum period. So that, 1 to 3 days just about following their delivery. And then post-discharge, it can be anywhere from the day they deliver or the day they're discharged through 6 weeks, generally is what we consider for a maternal cause or something related to the pregnancy, but actually it can be up to 1 year postpartum that patients have some side effects or can have side effects from their delivery. So within these periods, a couple of our really common causes of sepsis, especially here at JPS, we have septic abortion, so patients having a miscarriage or maybe a medical abortion for some reason, and they end up going into sepsis. Chorioamnionitis, so the infection within the membranes or the sac around the baby, and then pyelonephritis, so kidney infection, because if you think about a big pregnant belly is pushing all those organs into different places, putting pressure on them, and maybe the kidneys aren't emptying well enough, and it can kind of breed that bacteria. So during the intrapartum, immediate postpartum period, you still have that chorio, that pyelo, and then post-discharge, you have pyelo, wound infections, and those types of things that can really cause sepsis. So here at JPS, our top 3 are septic abortion, chorio, and pyelo. So I'm going to define those a little bit more here in the next couple slides. So chorio is defined by ACOG as an infection with resultant inflammation of any combination of the amniotic fluid, placenta, fetus, fetal membranes, or decidua. So it's common in preterm and term patients. Maternal morbidity from intra-amniotic infection can also be significant. It may result in dysfunctional labor. So if your patient has chorio, she has a fever during labor, her uterus might not want to function at the best of its ability. It gets really tired and hot. They can have postpartum uterine atony. Again, that uterus just doesn't want to clamp down because it is tired. It's been working really hard, which can lead to hemorrhage. Endometritis is when the infection happens. It's still within the uterus, but it is after delivery. It's called endometritis. Perinatitis, sepsis, you can have ARDS, and rarely death. Chorio occurs in about 4% of deliveries at term and approximately 8 to 50% of preterm deliveries. So our preterm babies, meaning before 38 weeks, they are at a higher risk, and our moms are at a higher risk of having chorio. Some of the clinical findings can occur before labor, during labor, after delivery. So you can have a fever. About 100% of patients have a fever when it comes to chorio. That's one of the first telltale signs. Maternal leukocytosis, 70 to 90%, maternal tachycardia, 50 to 80%, fetal tachycardia, 40 to 70%. You can have uterine tenderness, which can be kind of hard to diagnose, especially if they have an epidural. Bacteremia, which is common with group B strep, which is why it's really important that we know if our patients have group B strep or if we treat them for it. And then you can have purulent or malodorous amniotic fluid. So the treatment for this is at least 24 hours of usually AMP and GENT. So septic abortion, it refers to any abortion, spontaneous or induced, that is complicated by a uterine infection. It usually refers to pregnancies under 20 weeks. They can have pelvic and or abdominal pain, uterine tenderness, purulent vaginal discharge, vag bleeding, and or fever. And they might have bleeding currently, or it might have been within the past few hours, the past couple of days, depending on when the pregnancy is passed. If you think about it, your body really doesn't like to have necrotic parts inside of it. So once that's housed in the uterus can get an infection. The cornerstones of treatment are you want to give them lots of fluids, so that fluid initiation, antibiotics, and then you want to make sure that you get all of the material, all of the products of conception out of the uterus, whether that be through medication or through surgical. And then you have pyelo. So pyelo is associated with significant maternal and fetal morbidities, with complications including preterm labor, preterm birth, ARDS, sepsis, renal failure, and maternal or fetal death. So a lot of times you'll have that CVAT, that flank pain, fever, nausea, vomiting. About 20% of pregnant women with severe pyelo develop complications that include septic shock. So that's definitely something to think about when, you know, you have a patient, oh, she might have a UTI, she might have pyelo. We really do need to take it seriously. It's a big cause of maternal sepsis. So is it just pregnancy or is it sepsis, right? That's why it's so hard to diagnose this. Sometimes the signs and symptoms can mimic each other. Pregnancy and delivery changes just about everything that has to do with the maternal system. Some of the commonalities, you can have that systemic vascular resistance, you can have hypotension, tachycardia, tachypnea, all these things, ultraclotting factors, pain, dizziness, chills, all of these can happen in a normal delivery. All of them can happen in a septic patient. So you have to be really, really on point about what is going on with your patient and really be able to recognize it.
All right, so we're going to talk about maternal SIRS criteria. And another disclaimer, this is the criteria that we have currently at our institution here at JPS. I will let you know what the changes are for CMS, but I just wanted to let you know this is what we currently are using. So any heart rate that is greater than 120, respiratory rate that is greater than or equal to 30 would be considered SIRS. And remember, SIRS is your systemic inflammatory response syndrome. That's your body mounting that response to this infection. So that local infection is not just a local infection anymore. Now your body's responding to it. And so you can also have a fever. You can have a temp that is less than 96.8 or a temp that's greater than or equal to 100.4. For white blood cell count, less than 4 or greater than 15. And of course, if you have bands that are greater than 10%, that's also an indication. And those bands are those little baby white blood cells. So that's how you can tell. If somebody has bands, typically they're going to have a bumped white count as well. So symptoms of maternal sepsis, what are they? So Jess kind of went over a couple different things where pregnancy and sepsis kind of overlap, but some common symptoms that moms may come in with, they may be feeling like they're just generally unwell. They've got malaise, they just don't feel good. And maybe they have some lower abdominal pain that's not going away. Foul smelling vaginal discharge, that is often a telltale sign that something is going on. It can be from an undiagnosed STD during pregnancy. It can be a group strep. It can be yeast. It can really be anything. Bleeding from the vagina is never a good thing when you are pregnant, for sure. Foul smelling urine can be that UTI that then goes into pyelo that you have to be admitted to the hospital and treated for. Any dizziness and collapse can be cardiovascular unless otherwise ruled out. And then, of course, like I talked about, just the malaise, the fever, and the chills, because you can have that high temperature or that low temperature with sepsis. So some symptoms that might indicate sepsis. This is, again, from the World Health Organization, the WHO. But you may have some slurred speech. So you may have a family member think that their family member is having a stroke, and it's actually sepsis because they're not getting that oxygen perfused to the brain, and so they're not able to make sense. They may be shivering or have extreme muscle pain. Maybe they haven't passed any urine all day. That's a sign that maybe their kidneys may be affected. They may be breathless because of the fever, or maybe they have that pneumonia. They may have that feeling of impending doom where they think they may be feeling like they're going to die. Or they can have mottled or discolored skin. Those all can be symptoms of maternal sepsis. So I always want to check those patients out and see what the source is and what's causing this. So we talk about a source. So in order for a patient to be considered as septic, the patient must have a confirmed or suspected source of infection. So they may have pyelo, but they don't have the diagnostics back on the urine or the CT scan. So they may order antibiotics as empiric, which means to just treat generally for that infection. They suspect the infection, but they don't quite know the source. That's typically what they'll do is they'll order the antibiotics as empiric. A lot of times they'll do cefepime or Rocephin and Vanc. They do several different kinds depending on what the infection they think they're treating is. But then if they actually know, say the urine comes back and it's positive and it's got 100 plus white cells in it, then that might be something that they say that they are treating a documented infection because they know where the source is. So just the difference between empiric and knowing your source. So end organ dysfunction. So when we think of end organ dysfunction, think of this as you have pneumonia in your lungs, but you're now having kidney issues. So because of the pneumonia, your body had the SIRS, which was your systemic inflammatory response syndrome, and then it has a source. So now the end organ, it's not in the organ that the actual infection is, the local infection's at, it's in the end part. So it can be lungs, brain, kidneys, liver, all of those. So we're going to go over these right now. So in your lungs, if your patient is having to be put on BiPAP or CPAP or intubated, those are called invasive measures. And so that would be considered end organ dysfunction for these patients. So in their kidneys, if their creatinine is greater than 1.2, and again, this is for maternal, or they have not had, basically, if they've had urine output less than or equal to 35 mils per hour for 2 hours, that is considered an organ dysfunction for renal. And their brain, any altered mental status that is acute is always something that should be investigated. I mean, it could be a stroke, it could be a seizure, it could be sepsis. You don't know. So just, we want to always check that out, but know that that can be a sign of maternal sepsis and end organ dysfunction. So what about our heart? So if we have one, and actually this systolic blood pressure will change to 85 when we roll out with CMS. But at the time of this presentation, it was less than 90 or 40 below their baseline. So if their baseline is 160 and they're 110 systolic, that would again be considered an organ dysfunction. Any MAP that is less than 65 as well. And any lactic acid that's greater than or equal to 2.0 would be considered an organ dysfunction. So for your liver, INR can be greater than 1.5, PTT greater than 60. This is again not on any anticoagulation, so warfarin, none of that. And so platelets less than 100,000, and then T-Billy greater than 2. That's in absence of cirrhosis or anything that's chronic. Another thing to think about with this is when you have INR that's going up and a platelet's going down, your body is often getting ready to go into DIC where you clot and you bleed. And this happens a lot with our sepsis patients. It's the most common problem that we have when they start to have those, the INR go up and the platelets go down. It's that sign that something is getting ready to mount a huge response. So then what would severe sepsis be? So severe sepsis, again, is those 2 SIRS criteria. 2 of 4 have to be positive. Then you add an infection, it can be confirmed or suspected. And then you identify one of the end organ dysfunctions that we just talked about in the previous slide. So lactic, at least one. A lot of them will have several, but at least one. So it has to be the 2 of the 4 SIRS, add an infection, and then one of the end organ dysfunctions that we talked about. So it can be a lactic greater than 2, can be that blood pressure less than 90, any of those. And then you have severe sepsis. So severe sepsis is where we have end organ dysfunction. We got that hammered down. Now, what do? We have this patient, we have 2 SIRS and infection organ. What do we do? What's next?
So I can see the chat. So here's one thing. We'll discuss this here in a second. The problem is like we're saying, right? Maternal stuff and sepsis kind of go across each other. So it is hard to kind of navigate, okay, well, this is her blood pressure, well, she's on MAG. So we'll talk about that here in a second, how we kind of made out our algorithm for the special considerations that have to do with pregnancy as well.
But thank you everyone for putting your questions in the chat. We really appreciate it. That's awesome. All right, so 3-hour bundle. a lot of y'all may know this because it's one of the CMS measures that we have to report out. But to satisfy the CMS Step 1 bundle, as well as we have our own at JPS Joint Commission sepsis requirements, we have to satisfy that 3-hour bundle. So what is included in the 3-hour bundle is the initial lactic acid that has to be collected before IV fluids are given. You have to have blood cultures ×2. They should be from 2 separate sites, 15 minutes apart. IV fluids given 30 mils per kilo based on ideal body weight. So it requires a height and a weight to document this, but a lot of our OBs are giving this based on ideal body weight because they've got such a heavy load with the increased vascular resistance with being pregnant. IV antibiotics are to be given prior to after blood cultures, my apologies. And then a repeat lactic acid after the IV fluids are completed. So what else can happen is that you can have blood pressures. If you have 2 within 1 hour of that 30 mil per kilo sepsis bundle, IV fluid that is, so you have stops at like 12 o'clock and then at 12:15 you have a blood pressure of 80/40 and 12:30 you have a blood pressure of 70/30. You would end up, that would be persistent hypotension and that would be septic shock. So that's why we want 2 blood pressures within an hour of IV fluid. So it's not part of the metric like it states, but it is required to determine persistent hypotension. Kennedy, I saw your question about everything changed from a 3-hour bundle to a 1-hour bundle. So CMS is still with a 3-hour bundle, but I think that maybe what you're thinking of is a lot of insurance companies have gone to the 1-hour bundle, but we can get to that in questions as well. So just keep the questions coming and we will do our best to answer them for you. So time 0 is defined as once severe sepsis has been met by either clinical criteria, as mentioned in the slide previously, or a provider documents severe sepsis. And then you have all the criteria that's met for time 0. So then what would septic shock be? Well, septic shock is an initial lactic acid greater than or equal to 4.0. Or you have, of course, that persistent hypotension that we just spoke about, or you have a provider that documents septic shock. So if you have a patient with septic shock, generally vasopressors are going to be used. We use Levo here for the majority, but you can have Levo or Epi or vasopress. I mean, there's several different ones, but they require a lot of times ICU level care. So these patients are really, really sick. And when they're maternal sepsis, they're even sicker.
That's not usually a drip that we maintain in our maternal area. So usually that requires an ICU consultation and for them to be transferred to the ICU. Yeah. All right, so this is one of my favorite little boxes as well. Top 10 pearls for managing maternal sepsis. We've got our references at the end and this is included in there. So number 1 is just the most important thing to me. Under recognition is key. Always maintain a high index of suspicion for sepsis. Instead of sepsis being your last resort diagnosis, let's make it your first differential and try to prove them out of sepsis, right? Because it can look so similar to other conditions that have to do with pregnancy, it's really important that we always have sepsis on the forefront of our mind, not on the back, so that we can adequately treat it, because we know patients have better outcomes when we recognize it quickly, as well as their infants have better outcomes as well. So Pearl 2, implement a rapid bedside tool for detection of maternal deterioration. So as Jess mentioned earlier, sorry, we call each other Jess. As Jess A mentioned earlier, we have created a OB sepsis yellow sheet that we will go through here in a minute that really just helps the nurses just kind of go straight down to determine if the patient has sepsis and then what we're going to do about it. So you want to implement sepsis bundles to facilitate rapid escalation of care. Call your friends, right? Call everybody in that you think you need. If you need the MET team, if you need the ICU, get them there and let's get this patient treated quickly. Lab and radiologic studies are keys to search for the etiology and source. So, you know, we say chorio, we throw chorio around all the time, but really the only way to diagnose chorio is by examining the placenta after delivery. So that is a suspected diagnosis. So we really need to make sure that we're ruling out other sources. Know your bugs, their likely origin. Choose antimicrobials tailored to them. Fluid resuscitation should be initiated rapidly for patients with a lactate greater than 4. So we're not saying, oh, let's give her some fluids over a couple hours. This is within 15 to 20 minutes that we want to make sure that we've got usually 2.5 to 3 liters in.
And a pressure bag.
Yes. Again, that escalation of care is critical. Once the patient is stabilized, get to the source and anticipate and prevent adverse pregnancy outcomes. That's the whole goal of this. So we say that we have a toolkit here. We have some badge blings and badge buddies that we have created to kind of help our nurses and our providers be able to identify if their patients are, you know, headed down that road to sepsis and what to do about it. So we've got our SIRS. We have our end organ dysfunction listed on here. And the whole point is, again, we want to stop OB sepsis, right? So on the on the right-hand side, you can see SIRS is 2 SIRS source plus 1 acute end organ dysfunction equals severe sepsis. And we want to make sure that we are doing our initial lactic acid. Here at JPS, we do an initial stat ABG or VBG that is sent to our NICU that can be run within minutes. That way we are not delaying our treatment because, again, getting them treated, getting that fluid resuscitation going, drawing our blood cultures in all of our labs, and then getting our antibiotics going leads to a better outcome for the patient. That IV fluid of 30 mils per kg over 15 minutes using ideal body weight. And say for some reason we're not doing IV fluids and our initial lactic acid is still greater than 2, as long as it is documented as to why we're not doing our IV fluids, you know, provider documentation goes a long way. And so if in that case, usually you would draw a repeat lactic after your IV fluids, but you can then draw it after your first antibiotic is completed. So this is just kind of some, you know, tips and hints. And we really are trying to stress to our nurses to make sure that we are stopping everything in the MAR so that we can really determine when we are treating, if we're meeting our bundles or not. So here's our yellow sheet. When we print it out for the nurses, it's actually on a yellow sheet of paper. So it makes more sense. So this is the front side. And then the back side has our algorithm on it, which is going to be the next slide. So as you can see, if you look on the left-hand side, you've got your OB sepsis bundle. You can kind of do some check marks under SIRS. Okay, she had a fever. Okay, her white count is above 15. And we think she has chorio. All right, perfect. We are already meeting and we need to figure out what our end organ dysfunction is or if we have any. And then you've got your code sepsis, septic shock. Kind of how to define that quick and easy. So it's not too complicated to figure out. So then you can figure out when your time 0 starts. From time 0, you have 3 hours after that to finish the bundle. And it's so easy for our nurses. They actually love it. They can just check down over on the right-hand side. You can see the document the height and weight. Okay, got that. Initial lactic. Okay, I drew my BBG at this time. It was collected. It resulted at this time. Here's the value. Through the PDSA cycle, we have changed this a little bit, added more, taken some stuff out, but this is our original one, just to kind of give y'all an idea. And it really makes it easy. So then vitals times 2 after an IV fluid bolus. It makes it so that you can't really miss, because doing a full sepsis bundle is a lot, drawing all these labs, starting all these antibiotics, you know, doing all these things. So having a checklist really makes it easy. So there's a sepsis consult. So that is specific to JPS. When you put in a sepsis consult, you get Jess Aguilar to look at your chart to determine if that patient did meet sepsis, what we need to do if we met the bundle, those types of things.
And then we use this, like she said, through that PDSA cycle. So we send the information back to women's, and then they review these charts with their providers, and they have been essential in getting this collaboration, because the bottom line, I think, is it comes down to this collaboration, this teamwork that we have here. And, you know, I didn't expect for anybody to memorize the end organ dysfunction, but you don't know what to look for if you don't know what it is. So that's why we tried to make it more visible and easy for everyone to see and put it on the badge backer.
Because sepsis is hard. Sepsis it's difficult sometimes to really recognize. So here's our algorithm. So we have an algorithm for hospital-wide, that they use in the ED, they use in the ICU. And then we have an algorithm specific to women. So those antepartum, intrapartum, and postpartum patients. There's just a few things that are different. Now, if you look down at the bottom, there is a clinical criteria explanation. And over on the very right, there's a little pink box that says pregnancy associated conditions. Has the potential to impact some values utilized to identify an end organ dysfunction. Use your clinical judgment, right? So say you have a patient that has preeclampsia with severe features and her creatinine is 1.5. We're not going to use that creatinine of 1.5 as our diagnosing end organ dysfunction for sepsis if it's something she already has. It's consistent with her, right? So now we're going to need a different example of an end organ dysfunction or something else to be going on, because we have these patients all the time. Thrombocytopenia, right? Automatically her platelets could be 4. And you're like, oh, well, is it sepsis? What is it? Well, she has a diagnosis of thrombocytopenia. So we recognize that there are some pregnancy related complications that can change these lab results, as well as, you know, like somebody mentioned, based on the different trimesters, you might have different blood pressures. So if my blood pressure is normally 85/50, then I'm not going to take that and say, oh, she's obviously septic. No, that's her normal, right? So we worked really hard on this algorithm with not only our OB residents and faculty, we work on it with our family medicine residents and faculty who also care for our maternal patients. And it just kind of, it looks really busy. If you step back and just read each one, it kind of tells you exactly what you're looking for. We also took this, kind of the backbone of it is from the California Collaborative. So they kind of have a similar one that you kind of work through. So there's always a question of laboring and lactic acid, right? So lactic acid, there's not a lot of studies, but some studies show that it can be elevated during labor anywhere from 2 to 4, okay? So if your lactic acid is elevated and your patient is laboring, again, we added another caveat under here. So if that is the only abnormal, we want to closely monitor our patient. We want to do bedside assessment. We still want to do a fluid resuscitation. And then we want to do repeat lactic levels over time. Is it from laboring, from that uterus working so hard, building up that lactic acid? Or is it from her being septic, right? We need to figure it out. It requires more. You're not just going to say, oh, she needs SIRS. You know, we have a source and, oh, but she can't be in septic shock because her lactic is a 6, but she's laboring. That is not what we're saying at all. What we're saying is we need to do more studies. And if it's above 4, then your patient is in septic shock. That is not a normal for it to be above 4.
And I think too, there is a difference between laboring actively, like Jess said, and pushing than there is to just being in labor. So that's one of the things that CMS kind of does have clear definitions on, is that if the patient's in active labor, then that is considered to be that lactic that they won't look at technically. But if they're just in labor, not like active labor, they're just having contractions, that's not considered active labor. So I know that there will be a lot of things that come down the pipeline with this just because it's new. But you know, we found that opportunity to make this algorithm many years ago, and we have revamped it through our PDSA cycle and really just gotten it so that it would be something that all of the hospital can use. So we have, this is just for them. Of course, we have one for our ER that's specific as well, but this is just for the women's area. So it's really important, I think, just to realize the fact that this happens so quickly. A lot of times they go from early sepsis all the way to septic shock really quickly. So we're just trying to get everything on here. And this will probably be updated after CMS.
Well, we've already updated it once through the PDSA cycle, but it will probably update it again. It's going to have to be, because as things change, as in all of healthcare, we just update and go as it happens. Yep. All right, so here's a case study. We chose our favorite name because, you know, it was easy. So we have a 32-year-old female that is a 3-2 at 34 weeks gestation. So she has been pregnant 3 times. She has 2 babies at home, and she's currently 34 weeks pregnant. So she walks in at 12:25 to OB triage with complaints of right-sided flank and back pain, dysuria times 3 days, and reports a low-grade fever and nausea and vomiting. At that time, the nurse does some vitals. Her heart rate is 143, her respiratory rate is 32, her temp is 102.4, and her blood pressure is 110/78. So just by looking here, just right there, we have already met our SIRS criteria, right? Because our heart rate is elevated, it's above 120. Our respiratory rate is above 30. So it obviously right there, she meets it. But she also has a fever. So she's actually met 3 out of 4 SIRS criteria. So we want to give her, you know, specialized quick treatment because we already know she's meeting SIRS, right? She's got that right-sided flank pain, that back pain, and dysuria. So already those wheels are turning. Okay, this might be pyelo, this might be a UTI, right? So at 12:32, provider's already there. Nurses already let them know, hey, I need you. The provider orders a UA, a CBC, a CMP, blood cultures ×2, a lactic acid BBG, so it can be run very quickly, and IV antibiotics for suspected pyelo. At 12:46, labs are drawn, IV antibiotics are given. At 12:48, you've got your white blood cell count back. It's 18.9. So again, that's elevated as well. Our platelets are 59 and our lactic acid is 4.5. So let's think about that. So we already have our SIRS, right? We got our heart rate, our respiratory rate, and our fever. Then we also have our white blood cell count, which is part of our SIRS. Now we have our platelets of 59, which is less than 100, as well as a lactic acid of 4.5. So we actually have 2 end organ dysfunctions. The provider documents severe sepsis with septic shock due to pyelo. The patient is admitted to high-risk antepartum and is monitored throughout her stay. So we're missing one thing for this patient, right? So we talked about, great, we got all of our labs done, we've got our antibiotics going, but we've got to make sure that we do rapid fluid resuscitation, okay? And, you know, we've even talked to our MFMs, even if they're on MAG, we're going to do fluid resuscitation. It might be smaller, but we're still going to do fluid resuscitation. These patients need fluid. Their body is going into end organ failure. So we need to make sure that we are rapidly giving them back fluid, hopefully bumping up that blood pressure because I'm sure the blood pressure is going down. Just help kind of clear some of this stuff out, right? So this patient's admitted to high-risk antepartum with a lactic acid of 4.5. Hopefully we have consulted ICU. Our ICU friends have come and visited her. Her blood pressure is fine. She doesn't need any pressors, but we want to make sure that we're all on the same page and that we treat this patient quickly. All right.
So when we look at clinical findings for a maternal sepsis patient, we know that pregnancy can be complicated by severe sepsis, septic shock. We know that this also increases the chance of them going into preterm labor, the baby spending time in the NICU, having a fetal infection, of course. Preterm labor, sometimes it can be as early as 20 weeks when it's that bad of an infection. So we want to make sure that we are having our surveillance and our high index of suspicion for sepsis. And remember, your patients will rapidly decline. Like I said at the beginning, these patients are kind of like kids. When our kiddos, they just rapidly go down. Well, so do our mamas. They can have that quick progression from shock to MODS or death that incur within just a couple of hours. We want to make sure we're improving our outcomes. Go through your PDSA cycles and figure out something to get your detection of these patients quickly and promptly, get them source recognition, give them targeted treatment, and so that when they come up to this, they're not going to end up going into death and finding what their source is. And don't forget that the difference is always going to be you. If you think something's wrong with your patient, speak up. Speak up and say it. You are their voice, you're their advocate while they're in the hospital, and they are relying upon you to not just take care of them, but to take care of that baby that's inside of them as well. So you always have 2 patients in these instances. And at least, yeah, you can have more than 2. But yeah, so we just want to make sure that we're always listening to that little voice inside of us. So we have some takeaways that we'll go through, and then we will get to all the questions in the chat. But remember, early sepsis recognition saves lives. It really does. Always have that high index of suspicion for sepsis. And then, of course, CMS recognition of maternal sepsis beginning with 7/22 discharges is absolutely amazing. We are so happy that they're recognizing that.
Well, and one thing that helps them by recognizing it is it makes us, because then it has to do with our compensation, right? So we're saying, okay, I want you to do all of these things. The providers are like, oh, it's not that big of a deal. Well, now it's coming back to, are we going to get paid for her stay? Because if we do not meet these criteria by CMS, not only is her sepsis stuff not covered, her entire stay is not covered. So it affects a whole lot going on. So it's really important that CMS has recognized that maternal sepsis is an issue and that maternal patients are different than the rest of the population. So that's a big win in the maternal sepsis column.
Yeah, because prior to this, maternal sepsis wasn't recognized by CMS and it didn't have a different set of vital signs. So it's really, really nice to see that they're noticing that this is something that needs to have early recognition and really kind of monitoring that. Don't forget to always listen and look to your patients. Look at the way they are presenting. Look at their breathing. Listen to their breathing. You should listen to the breath sounds for an entire minute. And that's something that's really, we struggle with here is breath sounds and our labor and delivery, like breath sounds, respiratory rates, all of that. So make sure you're listening to their lungs because you don't want an pneumonia to be hidden under there and you just don't hear it because you didn't listen. We want you to make sure that, you're also checking cap refill. Look at all the things that are perfusion, because when it comes to sepsis, it's all about what is perfusing. That's why that lactic acid gets so high, is because you're not perfusing the organs. So just look and listen. Maternal sepsis is deadly. We've hit on that many times, but don't forget to look for signs that are not obvious and don't ignore that voice. It's within you telling you something isn't right. Use your tools that are offered within your organization. So for us here, we have the algorithm, we have the yellow sheet. We also had sepsis forums that we've done. We have skills fairs and CBLs that are built. So we have quite a few things that we have here. And then I just want to also say, Jess and I submitted a poster to A1 on this maternal sepsis, and it was accepted. So that poster will be on display there in June at Aurora, Colorado. So we're really excited about that. And sepsis can happen to anyone, anywhere, regardless of their socioeconomic status, background, medical training, or family connections. So just make sure, it can happen to me and it can happen to you. It has happened to me. I've been a maternal sepsis patient, so I get it 100%. And then this is our contact information. This is for me, Jessica Aguilar, and then of course, Kathy Watts, who's the sepsis coordinator. If y'all have any questions, that's part of there. This is the maternal levels of care team. So this is my cohort over here, and she is the third one down, Jess Brozio. She is their coordinator and has lots of amazing people on her team with Jerry and Shaylin, Sherry, and Audrey. And then now we have time for questions and answers. Whoops, sorry. So let me get to these. Let me see. So Megan, you had asked about the specs and exclude hypotension during active labor, and that you queried to get more information about this, what this really means. So they consider active labor. We just read it too before this. It just says active labor. It doesn't say pushing. So if you get something back on this from CMS, if you would mind sending it to the our sepsis strike force that we have monthly, and then that way we can get it out to people that want to know, because that's a really good question. They definitely didn't say laboring. They said active labor.
They said active pushing.
Active pushing.
Mm-hmm.
So then let's combine them and they say active pushing.
But again, so say your patient has hypertension during pushing, her blood pressure is taken while she's pushing, something like that. Your provider documentation always trumps whatever lab values, whatever vital signs values. Your provider documentation is the biggest thing. So if it says patient's blood pressure 80/40 at this time, retaken, those types of things can kind of rule it in or rule it out as well.
Yeah, and I mean, I think that that's this is something very new for the world of CMS. So there's going to be many probably updates to redo the lingo. So it may be different, you know, in 6 months when they do the January update. So just kind of a heads up on that. And then somebody had written, does this take into account gestational age, like first trimester versus second versus third? I don't know if that's related to our stuff, because ours includes that we had was anybody that is pregnant at any particular time. CMS is 20 weeks gestation to 3 days postpartum. So that's how they do that there. Megan had asked, do you find that the nurse determined 0 time typically matches the abstractor's time 0? I would say it's very, very close for the most part. It's probably within a couple minutes, just because they're looking at everything in real time, but we abstract it. We're looking at it from a past tense, like retrospective. So,
so the sepsis consult for Jess A. So it's just like putting in an MFM consult. It's just like putting in a nutrition consult. So we use Epic here at JPS. So we actually have a sepsis order set. And in that order set, there's the sepsis consult, and it goes straight to Jess's team. So all that it does is it triggers an RN review of the records. A lot of times we had some pushback from our providers saying, I don't need a team to come over here and, you know, evaluate my patient. And that's not what happens. It's really just going back through the documentation to make sure that we have the correct documentation so that we can get our compensation and make sure that our patient is cared for correctly and meeting those 3 and 6 hour bundles. So Jess does not she doesn't respond to the bedside at this point. Our nurses and doctors are told that if they need somebody at the bedside, that it's the MET team or a MET RN that they contact. So the sepsis consult, again, it doesn't have to be done before discharge. They can put it in. It doesn't hold up discharge or anything like that. So say it gets put in on a Saturday and Jess and Kathy are here Monday through Friday, then they do it when they get back and the patient can go on and be discharged with her baby, all those things.
Let's see. How does this, Lauren, how does this look differently at facilities with different OB and NICU levels of care? Because they're level 2. Our OB care team is not trained to care for this level of critical care in ICU and is not familiar with OB differences. How do we advocate to transfer patients early, and when do we deem a patient stable enough to transfer to a higher level of care?
You know, that's a great question. It really is. So one of the things about our maternal levels of designation is that it kind of gives us a roadmap for what we can care for, right? So it gives you a roadmap of what level 2, what level 1 through 4 can care for. If your patient is meeting maternal sepsis and you have a concern that she could decompensate and need a higher level of care, then that is a reason to go ahead and get that patient transferred. A lot of times we think that our patient has to be, you know, completely stable to transport, but there are transport companies that will take your patient while they are on pressors, while they are super sick, while they need ventilation. You know, that's what care flight is here for. That's what some of the other maternal transport is here for. They can monitor the baby while they're in the air or on the ground to make sure that your patient is getting to the facility that can give her the best care that she deserves and that she really needs for her and her baby. Now here at JPS, we are a level 4 maternal levels of care, and we are a level 3 NICU. So we do transfer our babies, you know, our babies that need cooling or our babies that need ECMO, those types of things. And again, those babies they're not necessarily stable for transport, but that's the reason why you're sending them, right? To be able to stabilize them. So it's something to reach out to your maternal program manager, your maternal medical director to kind of determine, hey, I think this patient needs to go. She could deteriorate and need care that we just don't offer here at our facility.
Robert, what is your monthly sepsis volume and what is your SEP 1 compliance? So our monthly sepsis volume is anywhere from 230 to 240 consults a month that we review. And our SEP 1 compliance as of this morning was 73.9%. So we are doing really well. Thank you for asking.
For our maternal sepsis volume, since we have rolled this out, which this rolled out January 11th of this year. Since we have rolled this out, so we went back 2 years. So looking at the year 2020, we had 5 sepsis consults. in 2021, there were 28. And through April, we looked and we already had 29 consults. We are on target to hit 115 sepsis consults from solely maternal patients for this year, which is a huge increase. It doesn't mean that we're seeing more sepsis patients. And that's one thing that we've talked to the doctors about a lot, is just because, you know, we're rolling out a sepsis bundle doesn't mean that our patients are now suddenly septic. Our patients were probably septic before. We are just recognizing it and treating it and diagnosing it now, instead of just assuming that it's chorio or pyelo.
And that's absolutely it. We're not just assuming that the infection is chorio or pyelo. We're actually treating, and our patients are getting really great care because of it. So really, really impressed by what we've been able to do. We've got about 5 more minutes, so I'm going to try to scroll through these.
Where can you find the CMS regulations?
Alexis Wells put it in there.
Oh, perfect. Thanks,
Alexis. You're the best.
She works with us as well.
Yep, she is the amazing inventor of those QR codes, and she's absolutely amazing. Anything else? Oh, code sepsis. So we do have a code sepsis that can be activated in the ER or in the women's. It's any like OB triage. So that area there is, you can activate that code sepsis there for a lactic that is greater than or equal to 4.0, or that persistent hypotension. So those 2 blood pressures less than 90 within 1 hour of those IV fluids completing.
And with that, you get an ICU doctor, an ICU nurse, you get RT, it's our MET team that usually responds. And so those are people that can help actually start treating that. We also have, here at JPS, we're very lucky, we have OB anesthesia on the floor at all times, and they also respond to those things. So
we are at the end of our questions. If anybody else has a question, throw it into the chat box.
somebody's
hand is raised, but I cannot see who it is. So if you want to just throw it into the chat box, or let Miss Patty know, or our contact information is there. Just let us know. We'll be there for you.
And maybe we'll see some of y'all at A1 this summer. Thank you so much, everybody. We really appreciate y'all. We both have a big passion for maternal sepsis, and I think it's a really important topic and really great for our patients that it's really coming into the spotlight.
Yes, our patients are definitely getting great care because of it. So very, very happy.
Thank you both. It was a great presentation. A lot of really positive comments coming out. We really appreciate it. And we can tell you're very passionate about this. And thanks for sharing. Will I be able to share the slides with the attendees?
I think we should be able to. Let me ask communications, because it's got some JPS stuff that's specific. So let me ask them, and then we'll be able to let people know from there.
Okay.
And we can double check on that yellow sheet and the algorithm to make sure that it's okay for us to share those. I don't see why not, but we'll double check. Okay.
Because there were a few people that were asking permission to use some of your templates, and so if you can clarify that. When I send out the email to everybody with the link for the evaluation, I will let you know what our answer is. So thank you, everybody, for joining us today. You will get the link for the evaluation. You have 10 days to do that. I will get that out to you this afternoon. We might not have an answer from our Jesses on whether we can share the slides, but I with the 10-day clock ticking, I want to get that link to the evaluation out to you. So at this time, we are going to move into our sepsis strike force meeting. I am going to stop the recording. We will have the recording